everyone. My name is Amanda Osorio, and I'm the Training Education and Event Coordinator at the Center for Healthcare Innovation. And I'm very happy to be here today to introduce our grand round on how the LEADS framework supports achieving health equity in Manitoba. For all of you attending online, if you could please ensure that your Zoom name matches the name that you registered with, and that way we can be sure to send you your certificate for accreditation. Those will be distributed this summer. All right, as we're getting started, we want to take a moment for an acknowledgement, as we really value this opportunity that we have to both reflect and to acknowledge the role that we play in this. It's not just at an organizational level, but at an individual level. So the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and the mistakes of the past and of the present, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So just to get started today, I'll share a bit about the connection between the LEADS and a Caring Environment framework and the Manitoba Quality and Learning framework. We won't go into too much depth of the frameworks themselves, but we're going to highlight the connection between the two. And then our wonderful speakers are going to share, Doretta and Faye. And then after that, we're going to have a time for some interactivity. We'll get some breakout room discussions going where we can share some practical actions and some resources. Just to start, we will declare that none of our speakers today have any conflicts of interest to disclose. All right, so as we all know, Manitoba's healthcare system has been undergoing a transformation based on a foundation of quality, safety, and a culture of client-centered care. The Manitoba Quality and Learning framework was developed to guide healthcare quality improvement for all Manitobans. So the framework includes guiding principles, aims, dimensions, and enablers. And one of the 4 principles of the framework is respect for every individual. The framework defines this as promote an organizational culture of providing high quality care to everyone, where the human rights, the needs, and the values of the clients, families, staff, and the public are respected. Now, under this principle, there are 4 key points, 2 of which are anti-racism and cultural safety. So if I can draw your attention to the green area on the screen under Healthy Manitobans, you will see the quality dimension there of equity. Now, in order to achieve the desired healthcare quality improvement for all of Manitobans, leaders must promote new ways of thinking and behaving that position quality and patient safety at the core. There needs to be a partnership between engaged leaders and empowered frontline staff in order to own and create the change. Culture change is required. The responsibility to guide that change rests with each and every one of us. So in order to accomplish this, in order to move the work of the Manitoba Quality and Learning framework forward, that's when we turn to the LEADS in a Caring Environment capability framework. So LEADS was adopted by the province of Manitoba back in 2014 as the leadership development framework for healthcare in Manitoba. The framework represents the key skills, the behaviors, the abilities, and the knowledge required to lead in all sectors and in all levels of the healthcare system. It represents a common understanding of what good leadership looks like across all levels in healthcare. So you'll see LEADS is an acronym for lead self, engage others, achieve results, develop coalitions and systems transformation. And these are called the domains of the framework. And under each of these domains, there are 4 capabilities. So these capabilities reflect those skills, those behaviors, abilities, etc. for each of these domains. The LEADS framework defines leadership as the capacity of an individual or group to influence people to work together to achieve a constructive purpose. The framework highlights that it is not an organizational position that makes someone a leader. It is not a title that makes someone a leader, but it's the ability to combine a commitment to improving with the knowledge of how to exercise influence and engage support. So the Manitoba Quality and Learning Framework provides the structure to create a culture focused on quality improvement, safety, and learning, while the LEADS framework identifies the capabilities that leaders need in order to develop and sustain that culture. So in essence, the Manitoba Quality and Learning Framework is the what needs to be done, and the LEADS framework is how to do it. So the connection between the two frameworks is extremely important and beneficial. So a few years back, the LEADS framework was mapped to the Manitoba Quality and Learning Framework to bring these two together. The mapping was done by Manitoba's Provincial LEADS Network, and they really played a key and important role of moving this work forward. So the mapping was done to assist both healthcare organizations and leaders in Manitoba to operationalize the Manitoba Quality and Learning Framework. It enables leaders to identify the skills, the knowledge, the characteristics, and the behaviors for success in operationalizing the Manitoba Quality and Learning Framework. The mapping demonstrates an interconnectedness of work in healthcare, bringing together concepts of quality and leadership. And it also helps leaders prioritize capabilities for development, both within themselves and within their teams. Now, here's an example of the mapping. You'll see along the left-hand side, you will see each of the domains of the LEADS framework and each of the capabilities. Across the top, you'll see the aims and the quality dimensions of the Manitoba Quality and Learning Framework. Now, every highlighted box represents an overlap where each of the capabilities are connected to the quality dimensions. So essentially, those are just check marks of which capabilities overlap. And if I can draw your attention to the orange area under Healthy Manitobans, under equity, every single capability is checked off there. Now we've broken this down even a little more. So here are some examples of the behaviors that promote health equity along the right-hand side and how they tie to the various domains and capabilities. So under LEAD Self, under self-awareness, the behavior is to be aware of perceptions and assumptions. Be aware of values and principles that underlie the choices and actions that leaders take. Under develop themselves, leaders engage in lifelong learning, adopt a mindset where every experience, opportunity, change, situation, challenge, and conflict is seen as an opportunity to learn. Under engage others, under communicate effectively, be sensitive to cultural nuances, use different forms of communication to capture attention. Under achieve results, set direction, create a compelling vision for the future that includes clearly defined outcomes. Again, these are just some of the behaviors that we wanted to highlight today. So in review, each of the capabilities of the LEADS framework, those skills, behaviors, etc., play a key role in achieving health equity in Manitoba. Now, I'm going to introduce our wonderful speakers today. I will stop sharing my screen so they can get their presentation set up while I introduce them. So we would like to welcome Doretta Harris. She is the current interim regional director with WRHA Shared Health, Indigenous Health. She's a First Nations woman from Sandy Bay, Ojibwe First Nations with a strong connection to culture and community. Doretta has worked in healthcare leadership for over 13 years in Southern Health, Santé Sud, and currently WRHA Shared Health. Her career has provided an opportunity to gain leadership experience in a wide variety of settings, such as working with many different Indigenous communities, Indigenous health advisory committees, board of directors, leadership tables, and different levels of government. Doretta has experience in leading and supporting Indigenous health patient services, integration, workforce, education and training, community engagement, and collaborative provincial partnerships across the healthcare system, as well as achieving national recognition for collaborative work in Health Council of Canada and developing a cultural resource toolkit that has been recognized by Accreditation Canada as a leading practice. Faye Tardiff is a Métis educator with roots in the Red River Settlement, as well as Mariopolis and South Junction, and a member of the key new local of the Manitoba Métis Federation. She has over 30 years as an inner city educator and has worked with students aged 12 to 25 years, as well as expectant mothers and infants. She has filled the roles of provincial academic achievement consultant, team leader, department head, and acting principal, in addition to English, drama, history, and psychology. She was part of a team of educators who wrote the Indigenous Voices and Holocaust and Human Rights curricula for the Winnipeg School Division, and was responsible for delivering professional development sessions for teachers in the Winnipeg School Division on these topics. So we'd like to give a warm welcome to our speakers today.
Thank you, Amanda. Hello, everybody. It's a pleasure to be here. Thank you. So our first slide, I'd like to start off with an acknowledgement statement. And this acknowledgement statement is one that was created by Shared Health. And it is that health services across Manitoba are provided in facilities located on the original lands of First Nation and Inuit peoples and on the homelands of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nation, Inuit, and Métis people in the spirit of reconciliation. So again, this statement is part of the ongoing work to understand the legacy of colonialism and repair relationships with Indigenous people. This is part of the commitment to the Truth and Reconciliation calls to action. And what's important here, as with any land acknowledgement statement that we read and use, is that we need to remember that these statements should never just become performative actions. Rather, we need to understand that when you hear a land acknowledgement statement, we need to consider and we need to ask ourselves questions and do some reflection, such as what am I doing to take care of and preserve the land that I am on, and how can I move forward with reconciliation? So our session objectives for today are really to better understand how LEADS, cultural safety, and the COI model are complementary frameworks. To understand how LEADS prepares us to work toward cultural safety in Manitoba, and also to recognize the connection between LEADS in a caring environment, cultural safety, health equity, and the Manitoba Quality and Learning framework. So we know we have some information on health outcomes for Indigenous peoples in Manitoba. We know that Indigenous peoples' health status is well below that of other Canadians. And according to a 2019 study from the Manitoba Centre for Health Policy, the health status of and access to healthcare by registered First Nations in Manitoba report, that this is not improving. The report shows that health outcomes are in fact becoming worse. These outcomes are directly related to issues of equity as expressed through the social determinants of health. Dixon AL in this article, as you see here on the screen, the relevance of the LEADS framework during the COVID-19 pandemic, tells us that the weaknesses exposed during the pandemic include clinician burnout, glaring deficiencies in pandemic preparedness, and Canada extended care standards, mental health delivery systems, and inclusion and diversity. That includes racism. So throughout the pandemic, glaring societal and health inequities have been brought into focus. These inequities further support the need for cultural safety and equity through individual, systemic, and forward-thinking leadership, as defined through the LEADS framework. So although new studies are forthcoming, initial data from the Government of Canada tells us that crowdsourced data indicate disproportionate impacts of COVID-19 pandemic on First Nation, Métis, and Inuit people. And that Indigenous participants reported greater impact on their ability to meet financial obligations or essential needs as compared to non-Indigenous participants. Also that Indigenous women participants in particular reported stronger impacts on economic well-being and mental health. Stronger adverse impacts linked to pre-existing vulnerabilities, including long-standing and persistent disparities in socioeconomic conditions and health. And some of these pre-existing health issues are illustrated in this table, as you see on the slide. So 18% of the population of Manitoba is Indigenous. And Winnipeg statistics report that we have the largest urban Indigenous population in Canada. Equity and cultural safety matter to us as healthcare leaders, not just from that care perspective, but also from a workforce perspective as well. This is important. So the report Reconciliation, Growing Canada's Economy by 27.7 billion provides us with the following information. That Indigenous people are expected to account for the bulk of future labor force growth, 52% in Manitoba, and that closing the Indigenous labor force participation gap will offer an even more dramatic upside for the Canadian economy. So Indigenous people will contribute as much as 1/5 of the growth in the labor force over the next 20 years. So therefore, as leaders who are responsive to future trends and who want to attract, nurture, and retain a representative workforce, we must incorporate the tenets of equity and cultural safety into all aspects of the working environment and our healthcare system.
So when we're talking about health equity, we're going to talk about Dr. Nixon's work and her COIN model in specific. So her work in public health looks at systems of inequality that exist and examines in detail the idea of privilege and its negative impacts. If we frame health equity issues as problems that face marginalized populations, then we run into the risk of addressing the needs of the groups without addressing the systems of inequality that exist or the unearned advantages enjoyed by some groups. In other words, we will constantly be creating band-aid solutions that cover up but do not ever heal the source of the infection. So Dr. Nixon's COIN model examines those, or imagines rather, the isms of society, sexism, racism, ableism, as coins. Each system is a coin in and of itself, and we carry several of them at any given time. We have a pocket full of change. Where we land at the top or the bottom of the system is as random as a coin toss. Landing on the top of the coin, having privilege, for example, for one system, does not negate the impact of landing on the bottom of the coin for another system. And it's the coin itself, not the person, that is the problem. Those on the top who carry privilege are often unaware that the coin even exists. Those on the top of the coin often feel as though they are outside of the system itself, when in truth, they benefit from it. More importantly, those at the top of the coin often try to create solutions for those on the bottom of the coin. Nixon's work says that this allows people on the top of the coin to frame their role in health equity work as neutral, selfless, and altruistic, when in fact, what they're doing by this approach is solidifying the system that's already in place. They're putting on that Band-Aid that I talked about. According to this COIN model, the true experts in health equity are the people on the bottom of the coin. You will often have heard the phrase, I hope you've heard it anyway, nothing about us without us, or with us, not for us. And you will hear that again in this presentation because it's critical. Keep in mind, intent is not impact. Policies and programs that do not include the voice of those they are intended to serve can and often do cause harm. The COIN model blends very, very well with cultural safety. And so what is cultural safety? Generally, it's acknowledged that the term originated in New Zealand way back in the 1980s. It's not new. It was first proposed by Maori midwifery students in response to feeling unsafe within the colonial or Pakeha system that they were being trained in. The components of the framework of cultural safety were further developed and refined by Dr. Irapiti Ramsden, as part of her doctoral thesis in nursing. And her goal was to overcome poor health outcomes due to the colonization of Maori people. Maori nursing students, midwives, and the Maori National Organization support the theory of cultural safety because although it sounds as though it's about culture, it's really about some important things like analyzing power imbalance, institutional discrimination, decolonization, and relationships with colonizers as they apply to healthcare. The framework, by the way, is being moved into education and business models, so it's being moved outside of the healthcare setting. Cultural safety is at its heart about understanding power dynamics and the sharing of power, and it's person-centered as contrasted with policy-centered. Ramsden saw cultural safety as a continuum, and you will often see it presented that way in the research. We at Indigenous Health put it on a cycle because we prefer to see it as a journey that will take time, continued learning, unlearning, and reflection. We are human beings, and as such, we cannot be fully culturally safe. We have to journey toward it and continue that journey throughout our lives. Cultural humility is the first step on this. And it's acknowledging that we don't know everything, that we all carry bias, and that we have to work to become aware of our own biases. When we recognize and challenge those biases that we carry, we reduce the risk of providing unsafe care and unsafe environments. Here to Help, which is a group of mental health and addiction nonprofit organizations from BC, defines cultural humility this way, and I love it. An approach to healthcare based on the humble acknowledgement of oneself as a learner when it comes to understanding a person's experience. This coincides beautifully with one of the main principles of the COIN model that tells us the true expert is the client, the patient, the racialized person, the person on the bottom of the coin. Cultural awareness. A big piece of this is learning about the histories, and I always hesitate to use the word history, but in order to properly understand intergenerational trauma and its effects on Indigenous peoples, we need to become aware of what those traumas are. We need to acknowledge and understand that colonial trauma is not in the distant past, which is why I don't like the use of the word history, but is recent and ongoing. Things such as the Indian Act, residential schools, Indian hospitals, these are not long past, long ago things. They are the experiences and the truths of our families and ourselves. Cultural sensitivity builds on that cultural awareness. We acknowledge there are differences between and within cultures, and we add the element of respect for those differences. We also look at our own experiences and influences and become aware of the impact that these have on our interactions with others. The culture, society, and family that we have been raised in impacts how we see the world and how we will connect and interact with others. This definition calls on, as you see on the slide, the courage and humility required to be culturally sensitive. But really, it is the courage of humility. True humility calls us to be brave, to take risks, to be open, and to acknowledge that we don't know everything. We are learners. Cultural proficiency doesn't require us to become experts in cultures that are different from our own. It means that we acknowledge, appreciate, and respect values and preferences and express needs of others, that we're aware of our own cultural influences on our interactions and biases, and that when in doubt, we ask for clarification rather than assume. It comes from looking at a presenting behavior in any situation and being aware of what we bring to the interaction, asking ourselves that. What are the biases that I am bringing with me into this interaction? And then cultural safety, but it's really not just one more step on a cycle or a continuum. It's a change of approach and how we address others, and it's a lifelong journey. It rejects the idea that cultural competence is an end goal in and of itself, and instead it strives to understand the systems of power and our positions in upholding or challenging those systems, that we rectify power imbalances through the use of a person-centered approach. Cultural safety in practice is the expression of the main goal of the COIN model, empowering those who are oppressed by systems and lack of privilege to determine if the interaction is safe because of their own lived experience as people who navigate those oppressive systems. And this is truly person-centered. Culturally safe leaders are aware of the biases that we hold, and we're critical of the power structures and systems in which we operate daily. It's about service leadership, the idea that leaders lead best when they truly listen. As leaders in the healthcare system, you help set the tone for the entire organization. And finally, culturally safe environments. Well, Curtis et al. Suggest in their 2019 article that organizations should begin with a self-review of the extent to which they meet the expectations of cultural safety at a systemic and organizational level, and then identify an action plan for development. In order to build those truly culturally safe environments, the coin model prescription of involving those on the bottom of the coin have to be a factor in the development of any planning. The coin model of health equity and cultural safety work well with the LEADS in a caring environment framework. LEADS was created to shift emphasis from a provider-centered model of care to a client-centered model, and cultural safety and the coin model are directly client-centered.
So cultural safety and equity are not disconnected from the LEADS framework. They go hand in hand. So as health leaders, we can use these frameworks to guide our interactions. They are not abstract ideas, but they're ways of guiding our actions and our interactions. So for the LEADS domain, LEADS in a caring environment tells us that self-motivated leaders are self-aware. They're aware of their own assumptions, values, principles, strengths, and limitations. They manage themselves, take responsibility for their own performance and health. They develop themselves, actively seek opportunities and challenges for personal learning, character building, and growth, and demonstrate that character. More qualities, model qualities such as honesty, integrity, resilience, and confidence. These capabilities help us to practice cultural humility. The acknowledgement that we need to learn from one another, and we admit that we need to be lifelong learners. We're open to assessing and challenging our own biases and assumptions. When practicing the coin model, we need to be aware of the positions that we occupy on the many coins that we carry with us. For the engaged domain, engaging leaders foster development of others. They support and challenge others to achieve and contribute to the creation of healthy organizations. They create engaging environments where others have meaningful opportunities to contribute and ensure that resources are available to fulfill their expected responsibilities. They communicate effectively, listen, and encourage open exchange of information and ideas, and build teams, facilitate environments of collaboration and cooperation to achieve results. We practice cultural awareness to understand the nuance of communication needed to build effective teams. We respect the lived experience of others, and we understand how colonial history continues to influence our interactions with Indigenous people. We utilize the coin model to ensure that we include the voices on the bottom of each coin in a way that is meaningful for Indigenous and marginalized people. In the achieve domain, goal-oriented leaders set directions. They inspire vision by identifying, establishing, and communicating clear and meaningful expectations and outcomes. They strategically align decisions with vision, values, and evidence, and integrate organizational missions and values with valid evidence to make those decisions, and take action to implement the decisions, acting in a manner consistent with the organization's values to yield effective, efficient, public-centered service, and to assess and evaluate, measure and evaluate outcomes, compare the results against established benchmarks, and correct as appropriate. We practice cultural sensitivity and use a person-centered approach that brings about genuine inclusion. It's not just about having someone at the table, but ensuring that this is a safe space for sharing that diverse knowledge and experience that is valued and respected. Cultural sensitivity, it requires us to be person-focused in our approach to staff and clients. It means that we follow the Indigenous research and approach on wise practice and use that in the way we interact with one another. We understand that effective interactions with others requires that we approach each person as a unique individual. We utilize the COIN model to ensure that those who experience systemic oppression have the opportunity and that safe space to be able to share their perspectives and experiences, and that they are leaders in guiding initiatives that affect them. This can include things such as research, data collection, and utilization. So again, that oppressed person is the leader in guiding initiatives that affect them. In the domain developing coalitions, collaborative leaders purposefully build partnerships and networks to create results, create connections, trust, and shared meaning with individuals and groups. And they demonstrate a commitment to customers and service, facilitating collaboration, cooperation, and coalitions amongst diverse groups and perspectives aimed at learning to improve service and to mobilize knowledge, employ methods to gather intelligence, encourage open exchange of information, and use quality evidence to influence action across the system, and to navigate that socio-political environments, are politically astute and can negotiate through conflict and mobile support. Cultural proficiency means that when we work with Indigenous people and other marginalized groups, that we practice the courage of cultural humility and that we ask when in doubt. We seek to never act on assumptions, but rather we are going to clarify. The COIN model means that we recognize that the experts are the people on the bottom of the coin. They will have the most important insight. Rely on their guidance and expertise. This is best summed up in the phrase, nothing about us without us, and with us, not for us. So in the systems transformation domain, leaders who are successful in systems transformation demonstrate systems critical thinking, and they think analytically and conceptually. They question and challenge the status quo to identify issues, solve problems, and design and implement effective processes across systems and stakeholders. They encourage and support innovation and create a climate of continuous improvement and creativity aimed at systemic change. They orient themselves strategically to the future, and they scan the environment for ideas, best practices, and emerging trends that will shape the system. They champion and orchestrate change and actively contribute to change processes that improve health service delivery. By practicing cultural safety, we empower and support Indigenous and marginalized individuals who use and work within those oppressive systems. Cultural safety is about addressing privilege and power inequities. When we are able to make changes within and between individuals, it is then that we are able to create system-level change and transformation that benefits Indigenous and marginalized individuals. The COIN model calls us to be aware of the systems of oppression, as well as the structures and the individuals who hold them in place. Systems are made up of people, and people have the power to move systems.
The individual aspects of the Leads in a Caring Environment framework and the COIN model work together, and they're supported through cultural safety. The COIN model asks us to be aware of privilege and engage in active allyship. LEADS challenges us to be forward-focused, transformative change leaders. It's up to each one of us to challenge existing systems of oppression and to listen to the expertise of those on the bottom of each coin. When this voice is welcomed, included, actioned towards effecting change, valued and sustained throughout all system levels, only then will we be able to make real improvements that will benefit marginalized and oppressed individuals and groups. The guiding principles of the Manitoba Quality and Learning Framework are respect for every individual, accountability, continuous improvement in learning, and value. These are met through utilization of cultural safety, leads in a caring environment, and the COIN model. Respect for diverse individuals and a person-centered view are the foundations of each of these frameworks. When we are inclusive of Indigenous and marginalized voices and promote true equity, then this will foster those positive effects on care team well-being and the patient experience. The ripple of the effect of this can, in turn, lead to the reduction of cost and diminished system stress. The Manitoba Quality and Learning Framework states that we seek to do the right thing to achieve the best results. Cultural safety, however, tells us that when we incorporate the Indigenous practice of doing things in the right way, then we will achieve the best results. Doing things in the right way means working with transparency, a willingness to learn, acting with respect, and in a collaborative and cooperative way.
Finally, we need to consider this basic truth. Health inequities have become extremely clear throughout the pandemic. Indigenous and other marginalized groups have been disproportionately affected. There's a tendency to want to return to normal, but it's very clear that normal has not been and is not working for those on the bottom of the coin. Therefore, instead, we need to resist that temptation to try to reset and go back to the status quo, because as I said, it was not working for those on the bottom of the coin. LEADS provides a structure that can be used going forward. Dixon tells us of prime concern is to continue the battle to overcome the health inequities that have surfaced and the importance of continuing to address these systemic patterns of discrimination that were inherent in the pre-COVID world. So if we are indeed future forward leaders, then we need to use these frameworks for change. So in closing, we have an opportunity with health system transformation to change and improve our current healthcare system, with the hope that it will become more responsive to the unique health needs of Indigenous and marginalized people, and to offer access to more equitable, culturally safe healthcare services that are reflective of those diverse values and beliefs. Further learning and understanding will assist us to provide a supportive environment for change that fosters a bottom-led, top-enabled approach. Doing so will build on the inclusion of diverse voices, with leadership involvement contributing to that broader culture change. So this will enable rather than direct change to take place. So this brings us to the end of our session today. It's been an honor to have been given the opportunity to be with you today and to speak. Thank you so much. Take care.
Thank you so much, Doretta and Faye, for that insightful presentation. You've really outlined really well how LEADS supports equity, not only by supporting the Manitoba Quality and Learning Framework, but especially in supporting the cultural humility to cultural safety cycle and the COIN model. So just a lot there to reflect on, and we really thank you for that great presentation. So we now want to engage all of you that have been listening to the webinar to share some strategies and behaviors that you have been using or you think you'd be able to use to promote health equity. We're going to be dividing the audience into 5 breakout rooms. Each room will focus on one of the LEADS domains, and you'll have a facilitator from the Manitoba LEADS Network in each of the rooms to support your discussion and record any of the strategies that you share. We will have 10 minutes to share as many strategies as we can by writing ideas in the chat, or you can verbally share your ideas. There's a LEADS key points document, and we'll receive a link in the chat rooms if you haven't received it prior to the webinar, and it'll help with the discussion. Our intention is that a list of strategies from all 5 LEADS domains will serve as a useful health equity resource going forward, and we plan to share the compiled list with this group and beyond. So Amanda has set up breakout rooms for us when she opens the room, and you might get a message where you have to click OK, but you will see your screen go blank, and then it will open up with a similar view except with a smaller group of people. And then after that breakout session is finished, we'll be brought back to the main room and hopefully have a few moments to have some highlights from each of the domains. Okay, so Amanda, please open the breakout rooms for us. Okay, I guess, hello everybody. I guess we're joining back. I hope you had an opportunity to highlight at least some of the capabilities in each of your LEADS domains and how they support equity or some strategies. So I will just start us off here, and we'll have each of the LEADS facilitators go through. My domain that I was, my group I was in was the LEADS Self group, which is the very first domain. So I'll just highlight there. I think we'll each have about a minute to 2 minutes to highlight a little bit that we talked about in each of our rooms here. So with the LEADS Self domain, we were actually quite quickly able to see how the 4 capabilities in LEADS Self, a few ideas for each of them, but it was a lot to do with self-awareness. So being really aware of our preconceived prejudices and biases that we hold, being aware that there's unconscious bias that we also hold that could be fueling our assumptions and decisions we make. The commitment to develop self with the lifelong learning and learning about people on the other side of the coin from ourselves, demonstrating character and being not afraid or embarrassed to admit when we don't know where the other person may be coming from, really being aware of power differentials and privilege, and recognizing how where our colonial Western medicine that we are used to may not be the right thing for the other cultures that we're dealing with. So those were some highlights from LEADS Self. So I'll now call on the facilitator from the LEADS Engage Others domain to share.
Thanks, Lisa. Susan here. We had a lively discussion, and I really appreciated everyone's willingness to share. We had a great discussion around promoting strategies and what was coined as down to staff. So being clear with goals and values in looking at fostering the development of others and in the sense of building trust. We talked specifically about words, and the phrase was coined by one of our participants as the words we use matter, and the consequences that can have unintended effects, oftentimes negative. And when we look at communicating effectively, this is something that the participants in our group really spoke about and would like to see occur. As well, the idea of accountability and moving forward, not only in theory and not only in ideals, but in substance, and shifting toward a real accountability sort of framework. Having a commitment and supporting leads and these models from senior leadership. And so I think that pretty much covers it. I had encouraged folks to type into the chat if there was anything else. Thank you.
Thank you very much, Susan. That's great highlights from Engage Others. So we'll move on to Achieve Results domain.
Yeah, so our group talked about how, it'd be good to look at wise practice with a focus on kind of departing from our Western way of thinking. So valuing various systems of knowledge instead of just prioritizing Western models of medicine. So perhaps just setting new direction or asking for buy-in or collaboration on what direction we're taking. And to have good strategies in place for collecting data from those marginalized patients and people that we're encountering otherwise. And I guess our domain regarded data collection. So just really collecting information on patient experience and outcomes of their experience to help inform how we are creating policies. And then using the Manitoba Quality and Learning framework to consider all the parts of the framework to see how they apply to that policy as we go forward. And again, just capturing more demographic indicators to measure patient experience as well as experience of our staff. And just a bit of discussion around the staff and to really look at our hiring practices to better reflect as well the demographics of our population, and just make sure that we're listening to the people that are represented from the bottom of the coin.
Thank you very much, Joanne. So again, great points. And really interesting as this goes along how LEADS has so many examples in health equity. Okay, we'll move on to develop coalitions.
Great, thank you, Lisa. Amazing how fast 10 minutes go. We had lots of points flying around. So some of them include making sure when we do develop coalitions that we're including diversity within those, and recognizing that our coalitions need to reach out beyond healthcare and really include representation from other industries, housing, education, so on and so forth. And including voices, not just of leaders and care providers, but voices from the communities, residents in the communities we serve, and the voices of our patients, residents, clients. We need to continually pursue our own learning, knowing that we're in a changing world and we need to reach out for that ongoing learning, be very active in that. And to be purposeful in choosing our methods of mobilizing knowledge. So one source of the latest research or the best practices isn't going to give us that diverse perspective. So really reach for a diverse range of knowledge. And using questions such as, what brought you in today? How can I best serve you? What's your picture or your goal of health? So we're able to hear from our patients, our clients. And one resource that was shared was the EQUIP website. So it's equiphealthcare.ca, a phenomenal resource for health equity out of the University of British Columbia.
Thanks very much, Sheila. For more excellent examples. And our last domain is systems transformation. We have Lily here.
Yes, we do. In relation to system transformation, there was a very, very good discussion in terms of some things that are happening right now, discussing biases and lenses with clinicians as they relate to the engagement of Indigenous groups in the service, having open conversations about cultural safety with staff, bringing speakers to facilitate conversations around cultural bias and Indigenous health, being meaningful when the land acknowledgement is used and I would say, mentioned, really meaning it. Exploring with staff, what does it mean for them when they practice? How do they bring in truth and reconciliation principles? It was interesting, somebody mentioned that there is an Indigenous Health Quality framework that has been developed and that could be looked at in amalgamation with the Manitoba Quality and Learning framework. And also, we didn't get to hear the full initiative, but there was an initiative through which the way in which kidneys were allocated to people in need was not serving the needs of the full community. That initiative recognized that there were disadvantages for some groups. So they had focus groups with the clients to learn from them what their needs were and better serve them. So lots going on at the macro and micro level.
Thank you so much, Lily. Thank you, everybody. And thank you again to our speakers. This has been an excellent presentation. Hopefully it's given you lots to reflect on and inspired you to learn more about all of the frameworks that we've discussed today. And we will be getting this compiled and sent out to all of you who participated. Thank you very much.